some of your panic competencies, and we're going to look at airway today.
Yeah, that's fine. Yeah.
Okay, so we want to go through, just talk about airway in general.
Yeah.
And then we want to then look at tracheostomies. We'll get those ticked off today. How's that sound?
That'd be brilliant. Yeah.
Okay, so we don't actually have any trachea patients on the ward at the moment. So we've got our lovely Ruby here. So we can look at what kind of tapes. We've got our trachea box as well. But we'll start off by, should we start off by talking about a normal airway for infants? So for someone like this baby size, going on to a child. What do you know?
So you mean like the differences in their airway compared to adults?
Shall we read the competency out?
Yeah, that'd be useful.
So the competency is describe normal airway anatomy and physiology and describe anatomical differences between infants and children.
Okay, so I know that so infants are obligatory nasal breathers. So that's something that's quite important, because if they get secretions or something in their nose, then it's going to inhibit how well they can breathe. So some of the anatomical differences. I'm struggling to remember.
So how about if we work our way down? So you talked about the nose, and then what's if we then say, so we've got the nose, and then next, what about the mouth? What do we think about infants' mouths?
Okay, so their tongue is larger in comparative to the size of their body. So and while we're actually up thinking about going top to down, it's their head is bigger in comparison to the size of their body as well for all children.
And should we just keep working our way down? So what else?
So the tongue, and then the airway is like funnel shaped, and the diameter is smaller, and the airway is shorter than in an adult.
So these are things that we then worry about in babies, don't we? Especially when you've already said that their heads are bigger and they've got smaller airways, so they get a bit of floppy heads. So these are all things, especially when they're unwell, that this is why we really think about our positioning, isn't it?
So the positioning, that's a good point. Positioning. So for a baby, it would be like a neutral position, and then for a larger child, you'd sort of go to the sniffing the morning air position.
Exactly.
For the correct positioning for the airway. Okay, so that's
that's also to do because it's a bit softer. The cartilage is softer. So if you were to do a head tilt in an infant and they've got a cone shape and it's softer, it
collapses it down.
Exactly.
Oh, and thinking about that, actually, it's also to do with their epiglottis is larger and floppier and different shapes. So the position that it would go in, if you tilt the head back, it may actually make the epiglottis sort of block the airway more likely, and it's why we might use different tools for if they needed to be intubated, thinking about that they've got a larger epiglottis.
Absolutely. So Stacey, one of your competencies in the panic book is to change trachea ties. So we've got two different ties here, so we can look at both of them. But what I would like you to do is I'd like you to just talk me through it so I can sign you off, and we'll demonstrate together. I'll be your second person, and then I can sign you off.
Okay, so I'll just talk through the steps that I would do if we were changing the tapes now, and then we'll do it. Okay, so before we do anything, I'm just gonna go back to what I would do beforehand. So I'd always make sure that I've got working oxygen and suction by the bedside. If we're fiddling around with the tracheostomy, we might cause additional secretions. There's obviously that additional risk that the tracheostomy could come out, so we need to be able to respond if that does happen. So I need to make sure I've got my tracheostomy box, and this morning I would have checked if it's got all the emergency equipment in it in case I needed to do an emergency change or we had a blocked trachea or something. So I have all my emergency equipment, plus the non-emergency equipment will be my next set of ties, a trachea dressing that the patient uses, and the wet gauze and dry gauze to be able to clean, and if they have any creams or sprays or anything around the stoma site, then I would get those ready as well, because we don't want to be running away from the bedside to collect things when we're actually doing the skill. So those are the things that I would prepare. Make sure that I've got somebody with me that is competent in changing trachea tapes, and I'd also go and let the nurse in charge know that that's what we're going to do, and make sure that there's nothing else going on in the ward at the time that means that we should probably put things on hold, so that they're aware of what activity is happening. And then we would talk through the skill together. I'd make sure that we've also got the sign at the end of the bed which talks through the NTSP steps for blocked tracheostomy, and you know, the size of the trachea and how far it's suctioned down to and everything like that. There's also, oh, I almost forgot, so actually preparing the patient. If they're a bit older, I would talk to them, make sure that they know what's going to happen. With a baby, I would try to probably swaddle them and get them to a content point. I wouldn't want to start it if they're sort of really, really grumpy, just about to go to sleep or something, or maybe talk with the family about what's the best timing for them. And then it's also about having a roll behind their neck to make sure that we can actually get to the neck easily enough. I think that's all the preparation. Do you think that covers that side of things?
Yeah, sounds like you got it all covered. Okay.